A very good evening to one and all. I am Arpita from the IGCP group, the moderator for today's session. The topic that we have come with today is relevance of glucose tolerance test in current scenario. And yes, without doing any further delay, I would like to introduce our speaker for today, Dr. Arun Raghavan sir. Sir is the director and consultant diabetologist at Dr. A. Ramachandran's Diabetes Hospital at Chennai. So, sir, now I would request you to please go ahead with the PPT and post that we'll take the questions from the audiences. Over to you, sir.
All right. Thank you for the invite. I'm very happy and glad to be here. So today, what I'm going to be discussing, how relevant is glucose tolerance test in today's era of diabetes management, right? Now, whenever we screen for a disease or diagnose diabetes for that matter, glucose tolerance test has always been the gold standard, right, for a number of years. But after which we had the arrival of the HbA1c, which was perhaps a game changer, right? In the current era, our go-to test to understand whether how the patient's prognosis is, or even for diagnosis for that matter, has always been HbA1c. And now, with the CGMS coming in, time in range is also gathering momentum, right? Now we are looking at time in range more closely, perhaps has advantages even more than HbA1c, right? So it is evolving. The metrics are evolving, the diagnostic tools are evolving. So at this point in time, does glucose tolerance test, which is far more cumbersome, time consuming, does that make any relevance in current era? Apart from diagnosing diabetes in pregnancy, of course, because that's still our go-to test. But generally, is it still relevant? Is what we are going to see, right? So screening of a disease, when should we screen for a disease? So the cardinal principles that is recommended by WHOs, the condition should have a recognizable pre-symptomatic state, and the screening procedure should be easily available, accessible to both public as well as hospitals, should be safe and universally agreeable, should also be cost effective, right? These are the cardinal principles for screening of a disease. Now, why are we talking about screening of a disease? Now, this is a diagnosis, right? So we know that about half the number of people living with diabetes in India are still undiagnosed. Now, that is the real burden that we are actually facing. We also know the burden of pre-diabetes patients in India. Now, these large chunk of patients, HbA1c may not always be the go-to test, right? Now, of course, a diabetic patient who walks into your clinic for a prognosis, also to understand whether the patient has been under good control or not, HbA1c is the gold standard. No arguing that. But patients at diagnosis, is GTT still a very important test that has been overlooked, is what we are trying to understand today, right? Why is early detection necessary? Early detection, diagnosing diabetes on time. Suppose we do HbA1c or we miss the patients, right? Then what can happen? There could be a delay in diagnosis, right? I'm going to show you a lot of patients in subsequent slides where we might have missed diagnosing diabetes because probably we brushed away those patients only doing HbA1c. So what could happen? We may be underdiagnosing or we may be misdiagnosing. And what these, considering the silent nature of the disorder, patients may perhaps check or screen after 1 or 2 years. So what happens in this due course? Diabetes kicks in, and then there could be, perhaps brewing. The uncontrolled blood sugars could be brewing. So this is exactly what we need to change, right? Because we know early glucose control, early diagnosis, early glucose control is the need of the hour, because we have learned about the metabolic memory or legacy effect. What is metabolic memory or legacy effect? Early glucose control, establishing early glucose control could keep your patients devoid of complications even after a couple of decades, right? But at diagnosis, if there are window periods of hyperglycemia, that could actually potentially culminate in complications later on, right? So that is why early diagnosis is the need of the hour. Apart from, of course, what I mentioned, early diagnosis also helps to improve treatment. It is quite easy, right? Suppose there is a delay in diagnosis, patients could land up in catabolic state, microvascular complications can start, they can spiral out of control, right? But if you diagnose on time, You can start off with lifestyle modification early on. You can start with metformin early on. They're quite easily handleable community, right? The patient's journey with diabetes lifelong is far more easier when you diagnose them earlier, right? Now we are talking about wellness medicine in one part of the country, and then we are also talking about preventing complications. Right now, this is what we are sandwiched in between. Here, we are looking at patients who are perhaps at the cusp of diagnosis of diabetes. These are the patients that we have to diagnose on time and establish early control, perhaps to preclude complications. So, what are the diagnostic tests for diabetes? Of course, as I've been mentioning, HbA1c, GTT, and fasting plasma glucose. OGTT, how is relevant? Before I go on to GTT, let's look at HbA1c. So I've already been alluding to HbA1c. However, let's look at some of the disadvantages of HbA1c, right? It may be less accurate for individuals with hemoglobinopathies. That is something that we are all cognizant of. Influenced by certain medical conditions. Of course, anemia, when there is low hemoglobin, HbA1c can be undependable. It's not dependable. Renal insufficiency, liver diseases can also influence the HbA1c. So conditions causing rapid blood cell turnover, such as hemolytic anemia, right? You may end up having a low HbA1c, right? Which could mislead your entire treatment pattern, right? And it is also not reflective of short-term changes. So like in pregnancy for that matter, or probably somebody who's at cusp of diagnosis of diabetes, right? Somebody who's perhaps just getting into the boundary of diabetes. HbA1c may not be the go-to test because it's a reflection of 3 to 4 months, right? So those are the disadvantages with HbA1c. More expensive, it's not currently a huge problem. Can be influenced by certain medications, particularly HIV treatments and steroids. As I already mentioned, at pregnancy, it may not be the go-to test. But what is the advantage of glucose tolerance test, right? Now, GTT, the advantage of GTT is that why are we looking at 75 grams of glucose, etc.? Now, why is GTT done? Now, suppose if I have 3 to 4 patients from different demographic regions, or in fact, let me talk about in my own clinic, if I have 3 to 4 patients in even different age groups, one may have a westernized diet, one may have a high carbohydrate diet of probably 3 idlis and pongal and vada. Another person may have a younger person may perhaps have pancakes and whatnot, right? They may have completely different dietary patterns, right? It is not uniform. Now, the postprandial blood sugar can be different for each of them, right? Now, this is where GTT comes into the picture, but because what we have is a uniform glucose challenge, right? To challenge the pancreas, the insulin response to the uniform glucose, and then look at the blood sugar readings, which can be interpreted based on a very uniform reference scale, right? So that's the concept of GTT. It is so that it is standardized for all patients, and then you have a reference scale to interpret where the patient's blood sugar lands, right? That's the concept of GTT, right? So that is why we at diagnosis we do not ask them to eat breakfast of their choice. The reference ranges, that's something that we are aware of. Normal blood sugar is usually generally less than 140. Pre-diabetes IGT is between 140 and 199, and diabetes is over 200 blood sugar. So about a couple of decades back, ADA was in fact of the notion that GTT should be thrown away, right? ADA didn't like it for some reason. They felt that it is very time consuming, it is cumbersome, and it is becoming a nuisance of sorts, right? So what ADA does is, how do we, kind of remove the GTT from the picture? So let's do something. Let's reduce the fasting plasma glucose levels. So suppose we reduce the fasting plasma glucose levels, you may not even need to do a postprandial blood sugar. We can just diagnose with fasting plasma glucose and then kick away the GTT out of the window. Now that's the thought process that ADA actually had a couple of decades back, right? Now, if you reduce the fasting plasma glucose levels, you could render the GTT inactive. I mean, throw away the GTT, eliminating the GTT, so possibly avoiding the cumbersome glucose as well as the postprandial blood sugar, right? So this was the concept. Now, unfortunately, this did not solve the did not actually solve the problem of avoiding postprandial blood sugar. So let's look at why. Let us imagine a scenario where fasting plasma glucose levels, were actually reduced from say 126 to 110 to 100, right? Now, the fasting plasma glucose actually is connected to impairment in insulin secretion, right? We know the pathogenesis of diabetes. While a faltering insulin sensitivity is very peculiar of IGT, right? So there is a pathogenesis in diabetes itself that we are actually missing here, right? So reducing the threshold of fasting plasma glucose does not mean that we will diagnose patients with other parts of dysglycemia, prone for other parts of dysglycemia, as patients who may have higher insulin resistance. Those patients may actually be missed, right? Because the diagnosis of the diabetes itself is multifactorial, right? We know that. So only looking at one metric, we may be actually losing out on diagnosis in patients who have insulin resistance. So that's where the notion of ADA or the thought flow of ADA was falling short, right? So, what about the metabolically relevant information? So alterations in insulin secretion and sensitivity are already present when fasting glucose is less than 100. This would be to no avail, as the majority of diabetics still originate from patients within the NGT range, right? So, to understand the entire glucose homeostasis, you need multiple metrics, right? Just looking at one metric, how can we diagnose or rule out diabetes, right? So that's exactly what the ADA, in fact, lost track. And but subsequently, in fact, with the emerging data that after ADA's recommendation and ADA was stood corrected. Right? Let's look at this study, which looked at about 654 patients. The objective was to assess the diagnostic power of ADA criteria in detecting glucose intolerance by performing an OGTT. Right? So look at the study. Out of the 202 subjects with fasting plasma glucose over 100, 121 patients had less than 140 postprandial blood sugar, meaning the postprandial blood sugar was absolutely normal, whereas the fasting was higher. Conversely, out of 452 subjects with fasting lower than 100, technically AD's recommendation is fasting is lower than 100, they're not diabetic. No, that's it. They're sent away. So, but over here in the study, it revealed that about 14%, 61 numbers, still had a 2-hour postprandial of over 140. So these patients would have been completely missed had we not done a GTT. So choosing an arbitrary number of fasting of 90, even at 90, 33 of 266 subjects, which means about 12% still had an abnormal 2-hour postprandial glucose, right? So we can never, with one single metric, there are a lot of patients today who go do a blood test, routine screening. They check one single sample, fasting, right? They do your thyroid profile, lipid profile, so on and so forth, and then that's it. They're done and they're packed away home. We may be missing patients with impaired glucose tolerance. Now, that is a key takeaway point that I want to drive today, right? We may have done HbA1c also in your fasting sample, still may not be foolproof, right? Postprandial blood sugar, particularly with GTT, is extremely important to diagnose prediabetes, or in fact, even patients who are at the cusp or at the threshold of developing diabetes. So, this data clearly demonstrates that any reduction of fasting glucose threshold is a progressive increase in sensitivity coupled to a progressive decline in specificity to detect high risk patients for type 2 diabetes. So you may increase the sensitivity, but the actual specificity is actually reduced. So only the simultaneous information obtained from the 2-hour postprandial glucose allows the screening to be comprehensive and effective, right? So what about pre-diabetes? All trials aimed at type 2 diabetes until now have included GTT. Not performing a GTT results in significant underdiagnosis of pre-diabetes in high-risk Caucasian population. Again, pre-diabetes is a very big window period where we can make much of a difference, right? Today we are talking about reversal of diabetes, remission of diabetes. And that has caught everybody's imagination. But what we need to understand is identify patients with pre-diabetes itself. Why, let them develop diabetes and then think of treating them or reversing them. Actually, the best window period to make a difference, make a change, is actually these patients who are pre-diabetic, because it's a quite a big window period where we can make a difference through lifestyle modification, where we can make a difference through nutrition, exercise, so on and so forth, right? So in this study, exactly about 47% were found to have pre-diabetes. Only 12% were newly diagnosed using the using the diagnostic criteria. Testing only HbA1c would have resulted in 78 subjects being diagnosed with type 2 diabetes. But 47.3% of newly diagnosed diabetes would have been missed if GTT had not been done. Of the 581 subjects with pre-diabetes, 257 in fact had a HbA1c of less than 5.7, right? So by the HbA1c classification, less than 5.7 is not pre-diabetic, right? But imagine 581 patients, of those patients who had a lower HbA1c, in fact, were diagnosed with pre-diabetes. Therefore, 44.2% subjects would have been missed. That's a large number, right? 44% subjects would have been missed if OGTT had not been done. It's a significant number. So this is another study which showed the relevance of OGTT for diagnosing diabetes mellitus based on the prevalence and incidence of retinopathy. Now, diabetes, as we know, is a very strong predictor of microvascular complications, right? Such as nephropathy, neuropathy, as well as retinopathy, right? So this study showed the correlation or connection between fasting and postprandial blood sugar towards microvascular complications, right? So based on the prevalence and incidence of retinopathy, the study concluded that both fasting as well as postprandial after GTT was important and relevant in diagnosing mild diabetes, right? And now that we've looked at diabetes, of course, GDM, I'm not going to dwell into this. This is something that we are all aware of, where HbA1c, you may use fructosamine assays, can be quite relevant because it's a short term, gives you a short term average of blood sugar. But however, again, GTT is the kind of go-to test in patients who are pregnant. So GTT can never be irrelevant. And again, to reiterate my presentation today, HbA1c is perhaps the best prognostic indicator that we have. And CGMS, although is there in today's era, we may not recommend CGMS to everyone, isn't it? Right? Who are the patients that we recommend CGMS? Probably pretty much all type 1 diabetic patients every year annually as per the recommendation. Yes, they ought to be on a CGMS, or patients whom we feel they are on multiple regimens where we are not achieving good glucose control, right? We need better insights to what is actually happening, right? So those patients, we may need CGMS as well. Or patients who are on secretagogues, insulin, who perhaps have hypoglycemia history, glycemic variability. Even in those subjects, we may need CGMS. But it is not a blanket rule for anyone. Suppose I have a patient who's well controlled, who has a reasonably good HbA1c, who's only on a DPP4 or a metformin for that matter, right? I don't expect any hypoglycemia, or I don't expect much of glycemic variability in such patients. So I wouldn't subject them to CGMS, right? So we know where to use CGMS as a tool. We are learning still. So we do not, as a blanket rule, recommend for all patients with diabetes. So similarly, I think GTT is a very important tool, particularly for diagnosis, right? Suppose if the HbA1c may not be always conclusive. So patients who are perhaps having a higher BMI or a family history of diabetes, I think these patients should be still subjected to GTT so that we do not misdiagnose or underdiagnose patients with diabetes, particularly in the Indian subcontinent, where we already know the burden of diabetes is huge. So with this, I'd like to conclude my presentation today. Thank you.
Thank you, sir. Thank you so much for your very valuable talk. Now, let us move on to the questions.
Sure.
Sir, the first question is with changes in lifestyle and diet over recent years, has the interpretation of GTT result evolved? And is there any new guidelines that clinicians should follow?
I mean, yeah, you see, after early identifying early glucose intolerance or diagnosing pre-diabetes, impaired glucose tolerance, definitely after that, diet as well as nutrition, exercise. We have the Indian Diabetes Prevention Program, which showed that exercise is as good as perhaps using metformin, whereas the Finnish diabetes program showed that metformin is pretty effective, as good or more effective than exercise. So, different demographics have shown slightly different results. However, I think the in the Indian context, I think once after diagnosing pre-diabetes, reducing starch intake, reducing carbohydrate intake, and improving your physical activity will definitely help in improving the metrics. And then, of course, after 6 months, you have to repeat a GATT to understand the trajectory towards either reversing diabetes or preventing type 2 diabetes for that matter.
Right, sir. Thank you so much. This one question is, Doctor, please let me know Rhizodec insulin twice a day and Oxtramet XR 10 by 1000 and ALSITA MP 100/50/1000 HbA1c is not going down from 8.6 or 8.5 and facing diabetic complications for a long time, especially CKD.
Okay, so if the blood sugar is not coming under control, I think we need to work up this patient. There may be multiple reasons, including patient's diet. I think this patient, if at all you're not able to improve the HbA1c, I think CGMS will give you definitely certain insights where we are lacking. Should we switch the patient to basal bolus, or should we, if we can do C-peptide, if patient has got beta cell reserve, then you can, start off giving sulfonyl ureas also. Rhizodec, aspat as well as deglutec combination is a decent insulin. However, some patients may require more boluses in the morning or afternoon. C-peptide as well as CGMS could give you deeper insights to titrate your medications accordingly.
Right, so thank you so much for answering this query. Another query is given the rise in pre-diabetes cases, how important is GTT in early detection and intervention? And is it recommended as a routine screening tool?
Absolutely. That's pretty much the summary of my talk because, as I was mentioning, only doing a fasting plasma glucose or doing a HbA1c, we may actually underdiagnose prediabetes, particularly prediabetes. In fact, I pointed out to a study where about 44% patients were underdiagnosed because of missing out on glucose tolerance tests. So, if you the key takeaway from the study and my presentation today is to rule out pre-diabetes, you definitely need a GTT, right? To diagnose diabetes is different, right? You have the HbA1c, so on and so forth. But to rule out pre-diabetes, definitely you may need a GTT.
Right, sir. Thank you so much. Here's the next question. Just in what specific population, like pregnant women or individual with family history of diabetes, is the GTT particularly valuable and why? Yeah.
Correct, correct, exactly. So, somebody who has a family history of diabetes, a strong family history of diabetes, and who has a higher BMI. Now, why GTT is important is suppose if the fasting plasma, again alluding to my study, fasting plasma glucose is 92, HbA1c is 5.6, you should not conclude that the patient is non-diabetic, right? Because subjecting this patient to a GTT may show that the patient may have insulin resistance, which may have post glucose blood sugar values of say something like 160s or 70s. Again, going back to the study. So, which classifies them as impaired glucose tolerance. So, it is extremely imperative to do GTT in patients who have family history or patients who have a higher BMI to diagnose pre-diabetes. Because once you diagnose pre-diabetes, you're actually, this is the point in time where they can make a difference. No, you can tell them with conviction, hey, this, if you allow this to go, you're going to land up in diabetes in a few years, right? So please change your lifestyle. Now, with conviction, this is where we can make a difference. So definitely, yes, you need GTT to rule out pre-diabetes. You can never conclude pre-diabetes with doing only fasting or HbA1c. Now, that's the key takeaway of my presentation today.
Right, sir. Right. Thank you. Thank you so much. There's one last question. That is, how does the GTT compare to other diagnostic tools for diabetes in terms of accuracy and clinical relevance today?
Pretty much again that I had mentioned. So uh, it is relevant, as I said, in diagnosing diabetes and pre-diabetes, right? That's exactly where this is used as a tool. Whereas HbA1c is used in the entire journey of diabetes for a patient, right? So what does HbA1c tell you? Two things. HbA1c tells you that the immediate past of about 2 to 3 months has been good. Also, HbA1c is a prognostic indicator of complications. So, the UK PDS and studies, we learned that the HbA1c reference range, which is threshold lower than 7 or etc., reduces microvascular complications, right? So, HbA1c is a good indicator for previous 3 to 4 months control, also a prognostic indicator to prevent complications. Whereas GTT is a tool that is used for patients whom we are trying to diagnose diabetes or whom we are trying to diagnose pre-diabetes. So that's exactly where GTT is of relevance. CGMS, I already mentioned, right? Where it is of relevance is, suppose you're not able to improve your HbA1c, or patients who have a good HbA1c or complaining of hypoglycemia, those are patients where CGMS is relevant. So each of these diagnostic tools are quite important. You have, depending upon the patient profile, they make a difference.
Right, sir. Thank you, sir. Thank you so much. So these were all the queries for today. I would like to thank you for like giving us your precious time and yes, sharing all your insights with us. Thank you so much, sir, once again for joining the Med Talks. And I would like to thank all the audiences for joining into the session and putting up their valuable questions for the same. Thank you. Thank you all. Thank you so much, sir. Thank you.
My pleasure. Thank you.
Thank you, sir.